if you want to give people time, or do you want us to just start?
Hello, Dr. Kara. Thank you. Hello, Dr. Kiruga. Hello, everyone. Dr. Kiruga is going to be our moderator, and we are at 31 members currently, so I think we can start. Karibu, Dr. Kiruga, you have the floor.
Thank you so much, Dr. Beryl. Can you hear me? Can everyone hear me?
Yeah, we can.
Okay. Yes, great. I'm glad for the opportunity to moderate the session today. As you know, welcome everyone to the webinar today. We're going to be talking about neonatal palliative care or perinatal palliative care. And I want to welcome all of you to today's session. Our speaker today is going to be Dr. Fanis Okara. We'll introduce the speaker today. We have about 60 minutes of discussion, and if you have any questions, you'll be expected to post them on the question and answer chat box, and we'll have an opportunity to interact with those. So I'm going to introduce the speaker today. Allow me to introduce Dr. Fanis Okara. She's a consultant neonatologist and pediatrician. Dr. Okara is a consultant neonatologist and pediatrician in private practice with a passion for advancing newborn and perinatal care. She completed both her undergraduate and postgraduate training in pediatrics at the University of Nairobi. And in the year 2017, she embarked on her neonatal fellowship journey at Imperial College Healthcare in the United Kingdom. Later joined Barts Health in 2018, where she worked in the neonatal intensive care unit and with the London Neonatal Transfer Service. In 2020, Dr. Okara pursued further specialized training at the University of British Columbia in Canada. Her professional interests include neonatal transport and perinatal palliative care, where she continues to contribute to improving the quality of care for newborns and their families. Thank you so much. Welcome, Dr. Okara. The stage is yours.
Thank you, Dr. Kiruga. That is really kind. I am going to share my slides now, and I've lost track of where they are. Oh, let me stop sharing first and then share again. So just to know that I have given this talk a few times. I find that the issues on the topic have not really changed. I think in terms of perinatal or palliative care, especially neonates and perinatal care, I feel like we are at the level, or in terms in Kenya, at exploring options, figuring out where we are exactly. So if this was a research question, I would say we're sort of exploring where we are, what do we do, what's the need, what needs to be done. And so I kind of don't feel, I feel like giving the talk more and more. For those who've had it before, so sorry. But and I think every time I have this conversation with people, there's a new nuance to it, basically. There's a nuance to it, sorry, in terms of something comes up, or I've come across something new that I add on to the conversation. I tend not to just read the slides. I just talk through what we're talking about. And today I think I'll try and go a little faster on the slides, so that at the end we can talk about options for what we can do in Kenya in terms of advancing neonatal palliative care services, and especially perinatal, but mostly neonatal. So in terms of introduction, so there's a difference between perinatal and neonatal palliative care services. So perinatal essentially means around birth or around delivery. So that will involve before the baby is born, and then during the delivery, and then after, which essentially means about 24 weeks. That's what it's sort of described as. But in most cases, you sort of start getting involved at 20 weeks in conversations you may not really actively get involved in terms of active management between 20 and 24 weeks, but you will be asked for your input, what your opinion is, things like that, basically, as a neonatologist. And then that may go all the way to, say, 28 days after the baby is born, or in some cases, it's defined as 7 days, basically. So that's the perinatal bit. Now, neonatal is after the baby is born, basically. So it's once the baby is born, and then you're dealing with that neonatal period. The reason I like looking at perinatal is because I think it's a continuum. So neonatal sort of means either you didn't know about it before the baby was born, and now you're having to deal with it now. But I would like to think that in a few years, we will know about these cases before. We will prepare the family better before the baby is born. If there's something that needs to happen before the baby is born, then the family can deal with it earlier. And if they choose to continue with the pregnancy, then you can deal with it in a different way and have solutions for every aspect of that baby's life. And then it's usually a multidisciplinary care, and it involves different aspects. So in pediatrics, unlike in adult care, you're not just dealing with one patient, you're in most cases dealing with 3 to 5 patients. By that, I mean you're dealing with that baby, you're dealing with the 2 parents, and then you're dealing with the siblings of this baby. And in some cases, you're also dealing with the grandparents and maybe even the aunties and uncles. So it's not as simple as you just have one patient in front of you. Let's just take care of this physical, emotional aspects of that specific baby. And a lot of times in neonatal services, we talk about family-centered care or family-integrated care. So you'll hear me talk about family a lot. So that essentially is what you're dealing with. So if you're dealing with perinatal palliative care services, so as I said before, you're either dealing with something where you know antenatally this baby has a diagnosis where they probably won't survive long after being born. By long, I mean this baby may not make it to adulthood. They may not make it to being a toddler. They may not make it to, being a teenager, basically. So those you're dealing with a shortened lifespan, basically, and those issues have to be dealt with from the neonatal aspect, and then going forward in terms of what needs to be done. And then that's one situation. The other situation is when you're dealing with a baby who will probably not survive because they are too premature to survive the circumstances around intensive care. So in Kenya, that would probably be before 24 weeks. And when I say 24 weeks, that's generous. I think a lot of the neonatologists, we mostly resuscitate above 25 weeks and above. Some do 24 weeks, but the success is, I don't know of any parents, of any neonatologists who resuscitate babies below 24 weeks. And all over the world, globally, most people resuscitate babies above 24 weeks. So there's no legal definition for the viability. Sorry, the viability age is defined as 28 weeks in Kenya, but I think that needs to change because a lot of us do resuscitate between 24 and 28 weeks. That changes a lot of things from a legal and a medical perspective in terms of what you can do, what you cannot do. I'll give you an example. So I currently work in UK now, and the viability age is essentially 24 weeks. So after 24 weeks, it's a given. You're going to resuscitate the baby once they're born. But before that, between 22 and 24 weeks, it's a conversation between the parents and the healthcare workers based on the circumstances as to whether the best option is to resuscitate or not to resuscitate. But after 24 weeks, you have to resuscitate the baby. Whereas in Kenya, if that cutoff is 28 weeks, so technically there's a whole argument as to whether, but essentially a lot of these babies are surviving. So maybe we should push that limit from 28 weeks to 24 weeks from a legal standpoint. And then sometimes, even in the best of cases, scans were done, nothing was picked up, baby was born term, baby comes out, and you either can clearly see from the time the baby is born that there's something wrong, or you are not 100% sure. The baby ends up being admitted into the neonatal unit, and then with time, you get a diagnosis, and then you realize, oh, we've not seen, there's no case reports or anything indicating that this baby will survive to 1 year of age or 10 years of age or something like that. So there are different situations in all those circumstances. So when you're offering palliative care services, you maximize on the quality of life, you reduce the stress and the distress, and then you honor the patient's values. Now, by patient values, these are parents' values, these are family values. The neonate will not tell you, I would like to be baptized, I would like to have, XYZ, I'd like to die at home and things like that. They won't. So it's based on what the family wants. And then there's definitions about what life-limiting conditions are from a neonatal perspective, basically. And those are laid out there. So if you look at the numbers in Kenya, I think we have roughly about 1.8 million babies born. And then there's about 60,000 babies who die every year. So whether that's stillbirth or neonatal deaths, it just varies basically. And sometimes even if you put in your neonatal deaths or other infant deaths, that comes to about 66 plus 53. So that's 100 and something, almost 120,000 babies dying. And then, so all those babies, either something has been picked up at the time the baby was born, or something is picked up afterwards, or they die from something that's preventable, like an infection or malnutrition or something else, basically. So those are all issues to deal with. So the palliative care is a growing field. Essentially, it started off in the UK, and then it grew from there, and it grew from there to other parts of the world. And it essentially started off with cancer and adult patients, and it's now gone down the tree to neonatal services and even perinatal services, basically. And it's actually thought to be a significant part of neonatal services because we work in intensive care. If you're in pediatric intensive care or adult intensive care, you know that there's no certainty, with that every patient you have will actually survive. So either on a monthly basis or weekly basis, depending on the frequency, you have to deal with death. So there has to be a way of you and your staff dealing with death, and then helping families go through it, and then as a community, basically, in terms of how we handle that. I was having a conversation, I think, on the neonatal WhatsApp group, and I was mentioning to them that if they look very keenly, that probably, which is very common in most hospitals, that probably 4 out of every 10 hospital deaths will be neonatal deaths. If you count in the stillbirths, might even be more. But if you think about where you work, think about how many babies die in the neonatal unit, and then think about the adults, surgical wards, the medical wards, pediatric wards, obstetrics. Very few mothers now die of maternal mortality has gone down in Kenya, basically, but neonatal deaths are still quite high. So if you think about it, it's 4 out of every 10 patients. And the question is whether those patients are actually receiving full services, including palliative care services. Now, I think the reason for that is you have lack of available programs. We're not trained to do these things. We don't have access, and patients don't have access as well. So it's very difficult to push the agenda. The challenges in Kenya are mostly legislation, and then not having clear guidelines, so national guidelines as to what to do. So as I said, so one of the things is, do we need to redefine viability age in Kenya? Should it be 24 weeks rather than 28 weeks? Should you say it's 26 weeks? Because, something like that. That's a discussion that we need to have. That's one thing. Then the next thing is we should have more and more people to train, and we'll talk about that at the end in terms of how to handle perinatal palliative services, and then having services available. There's loads of palliative services all over the country. We should integrate some perinatal or neonatal services into that and help families deal with it. And then when you're dealing with neonates, so in terms of legislation, so other than just changing that viability age, so a lot of times with adult services, you can de-escalate care, you can limit what you can do. So you can start off with a patient who's 95 years of age, is diagnosed with cancer stage 4, and you make an active decision not to take this patient to ICU when things worsen. So that's an active decision made while you have the diagnosis, and you can plan ahead. For neonates, the difficulty is we have a challenge in terms of getting accurate ultrasound reports, basically. So most of the times, 99% of the times, you have a normal baby born with no issues, and that's fine. And then in a small percentage of babies with abnormalities, some of them are picked up antenatally, and then there's a big chunk of them that's not picked up antenatally. So that means that when you attend a delivery, you might be expecting a normal baby, and they come out dysmorphic with features that don't look like they will sustain or be able to survive the initial neonatal period, basically. And they may look like they need breathing support. Now, the question is, you don't know the underlying issues. So you don't know whether this baby has abnormal lungs or small lungs, or maybe no lung at all. You don't know whether there's a cardiac condition that really means that this baby will not be able to survive. You don't know whether there's a brain or no brain, basically. You don't know any of these things. And if you follow the algorithm for resuscitation, you might end up intubating the baby. Now, under the current laws in Kenya, once you've established a certain level of critical care, you can't quite actually de-escalate that care. So once you've intubated, it's very difficult to come back and say, oh, wait, we have a diagnosis. There's actually no brain. This baby has significant cardiac issues, or there's actually no normal lung in this baby's body, basically. Or there's no kidneys, and this has happened, or something else has happened, or there's nothing. Something has happened that actually makes life impossible. So in most other countries, you can actually take the tube out and let the baby die and stop intensive care. But in Kenya, that would be very tricky. So we can't actually de-escalate care based on the current laws we have. What we do try to do is reduce the pressures the baby is on, and then that just sort of makes it easier, because it's quite challenging and difficult for the staff and the family to have a patient who's in the ward on intensive care, accumulating bills, and they're eventually going to die. Because that process could take 3 months, it could take 3 days, it could take years, basically. So it's not fair on the family, and it's not fair for the staff who have to take care of this baby. So what you can do is reduce the services or rather come down on what you're giving, but sustain the same service, the same care, and then naturally let life take over, basically. And those are the challenges. So we need legislation around being able to de-escalate care when you have definite diagnosis that this baby has a life-limiting condition that means that intensive care will not actually prolong or benefit the child, so which would be in the best interest of the child. And so that would mean you'd have a conversation with the parents and make a decision on when to actually limit care, basically. So that's the other thing. And yeah, so that's the same sort of conversation that we need to be having, basically. And I think from an African perspective, culture is a massive issue. So how do you discuss these things with the family and the bigger social or the community basically in general? It's almost a taboo to talk about death in Africa. So that being quite a difficult topic, then it becomes very tricky to have those conversations about a newborn. And so that's where it kind of gets a little tricky. So it's something to learn and see how to go about it. Now, one of the ways to implement services is essentially training is a big factor, and then learning what the needs are. So the needs of the staff, the needs of the family and the community, and in terms of the country, what do we need to do basically? And eventually, when we get there, palliative services have been shown to actually improve redirection of care and use of medication and actually reduce variability. So what I might do is not the same thing as what another doctor will do. It's not the same thing as what another nurse would do, because we all have different training, we all have different experience, we all have different levels of understanding, and we might actually do different things. They may all be the right thing, but we're just doing it a little differently. So if I'm on this week and someone else is on next week, then it might be a little bit different in terms of what the parents may experience or the family may experience. So you have to have very specific goals of care. As always, good medical practice, best interest for the child, best interest for the family, in terms of making decisions, make them together, and then prepare the family, and then coordinate services. So you want a seamless transition of services. So having a child in the hospital who then goes on to the community, it has to be seamless. It can't just be that the baby's on an NG tube, they go home. Once they get there, there's no nurse to actually help them in terms of fixing and taking care of the NG. There's none in the community to do all those things. So it has to be a seamless kind of service, basically. There's no doctor or pediatrician to follow them up once they leave. And there's no feedback in terms of any discussions that were had during the mortality meeting to the family in terms of what caused the death of this baby, if it was figured out, and if it wasn't figured out, then what else could be done? So those things need to be coordinated and done well. So WHO has its categorization of palliative care, which for those who work in palliative care services, you know this very well. So there are conditions that essentially in category 1, so life-threatening conditions. So curative care may be possible, but then it could fail. So those are things that you need to think about. And then in the second category, you have premature death, which is inevitable. So this individual will probably not make it to the country's lifespan, basically. And then you get to the next stage, which is progressive conditions without curative treatment. And things will just get worse and worse and worse with time. And then you get to irreversible conditions, which is category 4, where there's going to be severe disability and compromise of the health of this individual, which eventually leads to a premature death. So there's different things from a neonatal perspective that will fit into all those areas, and you just need to know about it. And then once a diagnosis is done, so this is the same in all palliative care services. So you start off with a stable patient, they then move on to unstable, then they deteriorate, and then there's the dying stage, and then there's the deceased, where you deal with what happens after. And there's a lot that happens after. And that usually means helping families and then sorting out all the documentation that needs to be done from a legal perspective. So once a diagnosis is made in a child's life, you connect them to palliative care services. And a lot of families tend to think that palliative care services, this essentially means that their baby is dying. And if you look at the 4 categories of WHO palliative care services, basically, or diseases, it doesn't quite mean that the baby will die immediately. And that has to be made very clear to parents in those situations. It just means that they might need support down the line. And so even if it happens 18 years from now, it would be good if they're actually connected to someone who helps them from a psychological perspective and social support and other factors, basically. And so in some situations, that referral can be done earlier on in neonatal services, or it could be done later on once they are in the community. And then they learn to live with the condition, and then there's the end of life and the bereavement aspects of it. So this is the same sort of discussion, basically. And then, so if you look at components of perinatal services, so we need to be training staff, and then we set up collaborative services between palliative care services within the hospital and those outside in the community. And then we need to measure what we're doing. So how much neonatal palliative care services are we offering? And then has it made a difference in terms of training or collaboration, whatever intervention you put in, does it make a difference? And then what areas and what hospitals and what communities are doing much better? Can we borrow and take that and then move it forward to another area and see if we can implement that? And then funding as well. And then having community awareness. So just letting the community know that just because your baby has been added on to the palliative care services doesn't always mean a bad thing. And it actually might be helpful in terms of you getting full services and closure of dealing with what happened around your baby's death. So one thing is, so there's services that will be more child-directed, and then there's services that will be more family-directed, and then there's the staff as well. So if we're dealing with the child directly, that's more clinical. So essentially it's procedures, tests, investigations, and then symptoms, and dealing with symptoms, the nutrition, if needed or not needed, and then the certain specific things that you might want to do that the family may want. So for neonates, you have to remember sometimes a baby is born, they go to the NICU, and the baby dies without the parents ever having been able to hold their child, which becomes a very difficult thing for families to deal with, especially mothers. So being able to make sure that at one point or another, in a safe environment and in a safe situation, the parents are allowed to hold their child and allowed to bond, which becomes a very crucial aspect of what they want, bonding basically. And then some parents may want to dress their child. So most babies in the NICU are naked. So they may want their baby to have a bath. They may want their baby dressed. Maybe they did buy something very special for their baby's delivery. So if they do have that, they could dress the baby up, they could take pictures, they could have, memory making and certain other aspects of palliative care that could be, teed up together. And then there's the after part of the death. So this is essentially just making sure all the documentation is filled correctly and accurately. The cause of death is filled accurately, what happened around the circumstances of the death, and if possible, trying to get a postmortem. So I think all neonatal deaths, there should be a postmortem done unless you have an antenatal diagnosis confirmed. So for example, if you've had genetic testing that shows that this baby has trisomy 18, I'm not sure whether doing a postmortem will add any value unless you want to make unless you are not able to do echoes or other tests that could give you a better idea of what the internal structures looked like or internal organs look like. But if you have a diagnosis antenatally, I'm not sure, but I'm sure pathologists would sort of argue that, yeah, doing a postmortem may add some value in terms of adding into the pool of information. So you may find an associated anomaly that's not really known to actually occur with this condition. Maybe it's a different genetic disorder, in the unfortunate situation that a child has 2 or 3 diagnoses at the same time. So those things, but it's worth having a conversation with the parents about it. And in some cases, so having that clear diagnosis actually helps these parents to deal with, one, that death, and then 2, prepare for the next pregnancy. Because if they go into the next pregnancy with a condition that is likely to happen again, then they are more likely to go through the same pain over and over and over again. But if they have a diagnosis, it might help them in terms of family planning, and whether that means that they change, they might have to adopt a child or maybe change one of the aspects of family planning. So whether that means egg donor or sperm donor or something like that, that might change the whole situation, basically, just to change the genetics. And in some cases, it might mean that you could possibly do some genetic treatments before you actually, embark on the next pregnancy. So it's quite useful in that situation. And then with the family, it's dealing with what happens around before the baby is born, around the time the baby is born, and then after the baby is born. So there are things that you could do practically, and then there are things that need to be, so that could be done to help the family and the mother. And they need to be family-centered. So you need to speak to parents, so especially when you're dealing with death and palliative services, it's good to talk to the whole family. By that, I mean the parents, and depending on the siblings' age, so if they're much older, and if they want to be involved, that's something you could bring in. So in some cases, you could have a 25-year-old sibling that might want to be involved. But in some cases, you could have a 2-year-old and a 3-year-old, so you're not going to call them into a meeting. But in that situation, if you have a 2-year-old and a 3-year-old, and this baby has been admitted in hospital for a whole month, those parents might need some help in terms of where do they leave these children when they come to visit the baby, especially if it's during school holidays and they don't want to leave them alone. And maybe they don't have a nanny and they live alone. Or rather, by living alone, they're not in a community where there's actually people who could help them with care. So setting up services that could actually help with sibling support, setting up services that could help the family with dealing with this situation. And then with healthcare. So as I said, if you're working in intensive care, if you're working in palliative services, there has to be a healthy way of dealing with death. So whether that's it's usually recommended that you have debriefing service sessions after any death. So there's hot debriefs and then cold debriefs that happen afterwards. And then there should be a mortality meeting from professional perspective where you discuss what actually happened during, and that would be the cold debrief basically. So those meetings basically where you discuss what happened from a medical perspective. And then in those meetings, you also look at what could have been done better in terms of perinatal palliative care services and how do they, and in certain situations, like when you do them in UK, you also do get feedback from parents. And that's actually projected out to the whole team. So whether these parents were happy with the obstetric care and the care of their baby, and then the care after the baby died. So that feedback is used to actually build the services and actually improve your healthcare services, basically, together with support. So a lot of intensive care units have psychologists. They don't always come every day, but it's good to have sessions once in a while that helps to support the staff, basically. And having sessions where you go out as a group. So maybe having a Christmas dinner or a Christmas, whatever, basically. If you're working in the NICU, prematurity days, you can go out, you can have cake, you can, having sessions where you actually do get to bond and be with each other and sort of share your experiences. And then because this is perinatal palliative care services, you have to have plans made in advance if you do have a diagnosis before. So what do we want to happen at the time the baby is born? What is the plan, especially if they're going to go forward with the pregnancy? So you have to remember that sometimes the parents will choose to terminate the pregnancy, and then your involvement in terms of a neonatologist that may end. But in terms of perinatal palliative care services, that needs to continue because that pregnancy loss needs to be dealt with from a psychosocial perspective, basically. And so services have to be made either way. And you have to have an advanced care plan for what happens if we have a pregnancy loss and what happens if we go forward with the delivery, what happens if the baby doesn't look like they will survive out of the delivery room, and what happens if the baby looks like they will survive and they will go to the NICU. So you have to have all those different scenarios basically and plan for them and have a care plan and meetings around them. And we've talked about that basically. Yeah, and yeah, I think we've talked about that. Yeah, and it's always good to prepare the parents about what they will see. So if a child has a significant deformity, it's good to tell them that once your baby comes out, they will have this massive swelling on their back, or they'll have this massive swelling of the head. Or you might not be able to have a vaginal delivery. You might need to have a C-section because of X, Y, Z. Or the eyes may look like they've popped out or something like that, basically. Just prepare them so that they don't have significant shocks when the baby is born. So that's one. And then two, it's good to prepare them with, once your baby is born, they may not breathe at all. Or you might see us attempting some resuscitation, or we might not do anything because we have very clear signs that the baby is not showing any signs of life. And it will be futile to try any resuscitation. So those are the things. And sometimes when you're having, like even with pregnancy losses, so if they have an extreme preterm baby, you have to prepare them because that baby may not look like a term newborn baby. So the skin will be fragile, the eyes will be closed, the skin will be thin, the baby will be very tiny in size. You may not see any hair, all those things. You have to prepare them so that they actually know what they're looking at when the baby is born, and give them an opportunity to express themselves and see what they want to handle and what they can and cannot handle. And then I've always learned this in palliative care: you should never ever predict the timing of death because we're never accurate. Actually, studies have actually shown that. And then you plan around the death. So this is important for the family. They may want to make memories, take pictures, wash or clean the baby, or give them a bath, clothe them. If they're religious, they may want some ceremonies done. So work around them. So once you make a diagnosis, so say for example, the baby is on, say, CPAP or intubated, and you've made a diagnosis, and the parents wish for the grandparents who live in Turkana to come down to Nairobi and see the baby. Allow for that because it's good for closure. And then you always have to remember that when you're working in a hospital, when parents leave your unit or where you work, you're not going to be with them afterwards. So if you do make significant decisions that affect the family and break that family down, you're not there to carry those consequences. So you can decide, you know what, the in-laws don't need to be here. We're going to do it tomorrow, whether they're here or not. That's not fair on this mother because you're essentially just bringing in another factor into that marriage. So those are things to look at and figure out. So if the in-laws say they're going to be there on Friday, today is Wednesday, you can do it on Sunday, you can do it on Saturday. It doesn't make much of a difference. It allows them to actually be able to properly do what they need to do from a cultural perspective, from a religious perspective, and everyone is satisfied at the end of it, basically. So in terms of training, there are a couple of things that could be done. So there's serious illness conversation guide. Now, this training is usually done to help with having conversations, healthcare workers to have conversations with families. And there's one for adults, there's one for children, and then there's one for neonates. I think the children is essentially the same as the one for neonates, basically, where you're breaking bad news. You're speaking to this family about the diagnosis you have, what condition they have, and then trying to explore options and care plan, basically. And it goes through different aspects, basically. So by starting off, you set up the conversation. So you're not going to have this conversation on the side of a room, or rather in a room with a bay with 6 mothers, and then you go and stand over her, and she's probably sharing a bed with another mother, and then you decide you're going to have that conversation with her there. So that's not appropriate. So you get a private room, you set up tables, chairs, everyone sits down, and then you make sure before you go into the conversation, find out what the name of the baby is. You don't want to keep saying baby Okara, baby Okara, baby Okara. You need to find out what the name of the baby is. And it helps them in terms of, it makes them feel like you actually are involved and you do care about their baby as well. So setting that up. And then the first thing I usually do is I assess what the parents and the family know about the baby's condition. So I usually just start by asking, what's your understanding of what baby X is going through, basically? And they will tell you, the baby was born, and then now they've been admitted into the unit, and they had a tube put in, and now they're on the breathing machine. And since then, the baby hasn't woken up. We haven't seen any change. The baby's getting worse. The alarms are always going off. And yesterday, someone came and told us this is the diagnosis, basically. So that's the other bit. And then you go through what they worry about, what you're sure about, what you're uncertain about, timing, function, all those things. So you have to read around the disease itself. So if you get the results today, it's good to let the parents know that you have the diagnosis. And then I tend to think that there is no rush in terms of having this conversation. And if I receive the results, say today at 8 p.m. now, I will tomorrow share the results with the parents and then ask them when they want to have this meeting. So tomorrow being Thursday, we can actually have this conversation on Monday. It doesn't have to be tomorrow. And the reason for that is you allow the parents to go Google, read around the condition, and prepare themselves and have an understanding. And then whatever they find, you can just share. So you give yourself time to research, you give the parents time to also research, you sit down, and then you actually give them the facts. And they may tell you, when we read around it, it said that the baby won't survive beyond a month. And you're like, yes, that's true. Baby, certain things you can discuss that based on what. Otherwise, you will walk into a situation where, and emotionally, you also prepare them. So they don't come in the morning, you give them the diagnosis, or you haven't really prepared them in terms of the meeting, what the agenda of the meeting will be. Is it good news? Is it bad news? So they need time to digest. Otherwise, you might end up with a very angry family, and you don't know these parents. You've only known them for, say, 2-3 days since the baby has been, 3 weeks. So you don't know how they handle bad news or good news. So sometimes it's good to give yourself time. Sometimes it's good to give them time as well, so that you end up with a successful meeting. And there's so many things to explore in the meeting. And then at the end, you always end the conversation finding out what the common ground is and what the next steps will be. And then you always document. The last thing you want to say to have is you made a care plan, you decided to do not attempt resuscitation, you didn't document, and then the parents come back and they say, we didn't agree to this, basically. So it's always important to have that documentation done, and always have someone else in the meeting with you. So just to back you up in those situations. We've talked about that. And in terms of sharing information, and then so decisions should always be shared. So there are different ways of making decisions in terms of end of life or care, actually healthcare, basically. So you can either make a decision as a doctor, we are treating this patient regardless of, and that's the way forward. And then you can have situations where the parents dictate what needs to be done. And then you can have a middle ground, which is the shared decision making, where you come with your facts, the parents come with their values, and their opinions, and then you get to a middle ground. You may agree, and that's a good shared decision-making situation or process, or you may not agree, and you get to a consensus. And sometimes if you can't completely agree, you can get a second opinion. And palliative care actually helps in terms of resolving some of those issues as well. And worst case scenario, you might end up in court. And then there's external factors to take care of, as we talked about, basically. So practically, who needs to be in the perinatal palliative care services? So nurses usually run these services very well. But you need the other doctors around that. You need clinical officers around it. You need social workers, psychologists. You need that whole team basically to work together. And then you need to have an agenda and a criteria as to who benefits and rather who qualifies and who doesn't qualify to be eligible for services. And it's like, I'll give an example. So like in British Columbia, so babies who had moderate to severe HIE and had been cooled qualified for palliative care services for up to 1 year. So, and if the baby survived beyond the 1 year, then they would actually be discharged from palliative care services. And if they died within the 1 year, then they would have gotten full services within that period, basically. So you can have different criteria for different situations, basically. So for example, like, say you have a situation where the treatment is, say, bone marrow transplant. Once that treatment is given, it's worth discussing whether they need to have palliative care services or not. So those are things to actually discuss. And then you need to have a scenario and an area and an ideal area to actually have palliative care services. So as I said, I don't think having mothers who've had a loss, or whether it's a pregnancy loss or a baby die in the unit, I don't think they should be in the same ward, a postnatal ward, with other mothers who are establishing breastfeeding. I think that's cruel in a way. So those are the things to sort of think about. Should they be in a different room? Should we be nursing them in different rooms? Things like that. Those are things to think about, basically. And it's good to always have a protocol, a checklist, and that can come from the ministry, and then you streamline it down to what works for your organization, and then moving forward, and then teaching services, basically. So teaching, training, that has to be in, collaborating with other palliative care services, audits and research, and then funding as well, as we spoke about before. So I think, as I said before, so the UK is very well positioned in terms of palliative care services. And they have a very well organized palliative care services from a national perspective, which has come down and trickled down to the different units, basically. So I thought, as an example, it would be good to learn from that system and then figure out what to carry down from there and take from there, basically. So there's different ways of categorizing palliative care services and around the perinatal healthcare services, basically. And those are in 5 categories, which are spelled out there. And then, so this is just another way of looking at it. So when you're dealing with palliative care services, are we focused on trying to ensure that this child survives? Or are we trying to ensure that this child has a respectful end-of-life care service, basically? Now, you can have what we call parallel planning, where you can have a child who comes who is born, was absolutely normal, maybe has HIE, is undergoing cooling. And at, say, day 2 to 3 of life, you're not 100% sure where things are going, or maybe the first 24 hours. So you will focus all your services in terms of making sure that this child survives. But if you get to, say, day 3, 4, and you're starting to think that we're not sure whether this baby will survive, you will still do your survival focused care. So intubation, all those things will happen. But then on the other hand, you need to prepare the parents, rather prepare the other aspect of it. So what if this child dies? And that's where you have parallel planning. And so you call in the perinatal palliative or palliative care services, and you talk to them about what you are dealing with, what the circumstances are, and what you should be doing. So you explore those options basically. And then, so if the baby survives, then you focus mostly on the survival aspect. And if the baby doesn't start to improve, then you can quickly switch over to the other side, basically, on both ends, and have everything prepared. And there are different key elements in terms of perinatal palliative care services. You have to empower the staff, you have to plan, you have to treat any symptoms that need to be treated, you have to deal with the loss, and you have to give support as well. And this is just a tree just to see how you go about it, and discussions all through. There's something called a surprise question, and the surprise question is, would anyone be surprised if this baby died? And if the answer is no, then you have to think about palliative care services whenever you're doing critical care. And then we can talk about this bit. So I'm just going to stop sharing, and then we can talk about this and other, sorry, not stop sharing, yeah. Actually talk about what other things we could do. So I think I've spoken a lot about what we could do, which is essentially legislation is very important, training, funding, research, audits, and collaboration, basically. And one thing I noticed today, I think in a couple of emails I saw Esther and Beryl send around, I think to me as well, was there is a training, I want to say it's ICPCN, basically. There's a training on neonatal palliative care services, and I actually looked at it a little bit today, and it's mostly it looks like it's UK based, and it's meant, I think, for, correct me if I'm wrong, Beryl, it's meant for the global health community. I think it's worth going through it if you're interested in neonatal palliative care services. To give yourself some aspects of, understanding of what goes around palliative care services in the neonatal field. I think that's it.
Thank you so much, Dr. Fanis Okara. That has been a very interesting discussion. And we're glad that you've shared with us wisdom, and more so what you've been practicing in UK. I'm glad that you have your tab on what is happening in Kenya. I was actually going through to see whether there are any questions that have been posted on the chat. I have not seen any. I would like to remind you, if you have any questions, post on the chat, or at least raise your hand, and you will be enabled to maybe communicate. But as we think about the things that you've talked about, maybe one of the things I could ask is the topic. We had neonatal palliative care, but I think you explained very well and discussed around perinatal palliative care. So in terms of what you think, should we be talking less about neonatal palliative care and preferably be using perinatal palliative care? And then there are other questions that will come as you discuss that. Dr. Fanis?
Yeah, I think that's a very good question. So as a pediatrician, as a neonatologist, I am inclined to think that we should focus on, I think both are important. And I think it's also difficult to, take one and not focus on the other bit. I think as pediatricians, we focus mostly on neonatal services, so neonatal palliative care, and that's where we're mostly involved. But if you've ever worked with palliative services, especially children's palliative services, they offer services around perinatal palliative care. I did 1 month in Canada with palliative care, children's palliative care services, and a lot of what you see in the NICU is what we deal with in the NICU. When the baby is born, and then you're dealing with that palliative care service or situation. But when you're in the palliative arm, what I saw was, oh wait, actually there's a pregnancy that they need to, kind of look at and sort of deal with. So there's a whole other angle that we don't see before the baby is actually born. Now, if we're going to accurately deal with it, the question is where maternity is, because perinatal losses are mostly maternity services, right? So you're dealing with a pregnancy loss, a stillbirth, or one of those basically situations. Now, do they offer services in maternity that will support these families and women? Because it's very tricky for me as a neonatologist to go and offer support to 16-week pregnancy loss. It's not really under my, remit at all, basically. But if it's a 28-weeker, 29-weeker, that could be within my field, basically. So I think it's worth exploring what maternity are doing and then trying to see if we can collaborate. And the reason why I think they are connected, so as I said before, is it fair for a lady who's just lost a baby during a delivery to be in the postnatal ward? So if we as neonatal doctors decide, no, I think this lady should be in a different room and things like that, and how do we help her with that loss? We don't actually take care of women, right? So we can't really dictate to these those services where they can actually house this mother. We need to be talking to them and figure out what to do. So that's why I think it's sort of connected in a way, and it's very difficult to disconnect, but there are aspects that are completely perinatal or rather prenatal, and then there are aspects that are very perinatal, and then there are aspects that are completely neonatal. But a lot of what we deal with in NICU then drives into the pediatric palliative care services, because in some cases you make a diagnosis and this baby will not actually die in their infancy. They could die at 15 or 20 years of age. So you need to deal with the pediatric services a little bit more. I don't know if I've answered your question.
Yes, thank you. Thank you very much. You've answered it pretty much well. I appreciate. There's a question on the chat box by Dr. Kinyanjui. How best do we promote genetic testing? And then, maybe a bit more comment on availability and acceptability of that in Kenya.
So I worked in Kenya for the last 2-3 years ago, basically, or a year ago. Essentially, there are services available, and I think Catherine Mutinda would be the right person to talk to. So she's a geneticist and she's a pediatrician. The services are available. I'm not sure how available they are. They are generally well accepted. The problem is the cost, because this is going to be private costing, basically. I don't think SHA will pay for genetic testing. In some cases, it could cost 100,000. So I don't think they pay for that. And then in some cases, you deal with parents where they say, we don't want to know. So, but that's the same even here. Even here in UK, you can have parents who are like, we don't want genetics, because technically you need consent to get genetic testing. I think from a data protection aspect or a legal aspect, that is a massive thing. So if you're testing, then you kind of need to get their consent. So you can't just test for the sake of testing. So there are parents who will tell you, no, I don't want genetic testing, and that's fine. And then you try to deal with the situation as it is. So it is available in private sector, or rather, even if the patient is in a public hospital, they do need to pay to have the services done, which are done in private institutions. And most parents will agree to it if they can afford it. Yeah. The issue now again comes down to sometimes insurance companies may not agree to pay for it. So there are a bit of challenges there, but it's something you can add on to SHA as services because it's essential, I think, in terms of making a diagnosis and going forward. Because in my opinion, I don't think a lot of what we see on death certificates as sepsis is actually sepsis. It could be a genetic disorder that manifests with symptoms that are very ambiguous, basically. So you can have difficulty with breathing and ETAT, that could be sepsis, basically. But it could be a metabolic disorder that is a genetic disorder diagnosis, basically. So it might actually help in terms of linking services and actually expanding services as well.
Oh, thank you. While at it, yeah, our work is well cut out. We definitely need to start conversations with SHA and how we can include that. Maybe we probably might have to start by documenting the magnitude of the problem and probably using figures and evidence. We might be able to convince the country, Kenya.
Sorry,
the other question.
Dr. Mutinda
Yes.
has that data.
Okay.
So it's worth talking to her because I think she has data on that basically. I think so.
Okay, I'm not sure whether Dr. Mutinda is among us today. But yeah, thank you. We will follow up that. The other question that I think probably ran through my mind as we were as you discussed the different aspects of perinatal palliative care. One of the things that I think came up very strongly is the discussion on viability, and I think you talked more about Kenya defining viability around week 28, and the possibility of us moving it to 24. But these discussions have not taken place, and I think if I heard you well, one of the things you are saying, we need to change this. And my question would be, how do you think, what are the practical aspects that we should take to begin this conversation, and how do you think as a country, Kenya as a country which pathway should we take to start this conversation? Who should we talk to, and what should we do? Any thoughts on how we can implement that?
I think one way to go about it is data, one. So just to note that there was a meeting this afternoon, I think COG, something to do with mortality around the perinatal period, basically. So Dr. Manyasi was representing the neonatologists and the group in terms of mortality and dealing with mortality around neonates, basically. Now, one thing we can do is collect data, show essentially of deliveries between 24 and 28 weeks, and then looking at the survival rates of those babies at the time of delivery, and then going forward, what their outcomes are, basically. Now, if you have 80% survival of 26-weeker babies in a hospital, for example, in say Nyandarua, as an example, basically, there's no reason why the viability age should be 28, because that means essentially in Nyandarua Hospital, if 10 mothers come in with 26-weeker babies, technically 8 of them will go home. They may not all survive to 2 years or 10 years or something like that, but say 8 of them go home. Now, if you have data to show that actually a lot of hospitals do have babies who are surviving and are being resuscitated between those gestations, it might be able to push the needle forward, or forward, basically, to improve services. And the reason for that is, if we don't move that viability age, you will have health facilities where, or healthcare workers who say, 26-weeker, I'm not even coming to attend the delivery. Don't even call me, basically. And the baby comes out crying and just needs a little bit of some breathing support and they're fine. Or they may not even need any breathing support. Unlikely, but yeah, that's one issue. And then you might have situations where in a certain healthcare facility, then they're all being resuscitated. So you just need uniformity and regulations. And then a lot of data has shown, especially for neonatology, that when you improve care for the previous, say, block of preterm babies, when you consistency is the word of the day, basically. So if you, as a healthcare institution, regularly take care of 26-week babies and they survive and go home, the mortality rate for your 26-weeker babies may be 20%, for example, but your mortality rate for 28-weekers might be 10%. And the ones for 30 might be 5%. And the one for 32 might be 1%. And your 34-weekers are essentially surviving and going home. So what I mean by that is you actually get better neonatal outcomes if you improve the care for your smaller babies. So you improve the next batch of preterm babies, basically. So units where they take care of, say, 22, 24-weeker babies consistently, their outcomes are very good for 24 to 26-weeker babies. They're very good for 26 to 28-weeker babies. And they're much better to 20, because if you're taking care of the smallest babies and they have good outcomes, it means that if you're given a slightly bigger baby, your outcomes will be much better. Okay. And I think if we have data to show that some units are taking care of, say, 26 to 28 weekers, maybe 24 to 26, you can break it down to batches and see where we are doing well, where we are not doing well, and why are some units doing well and others are not doing well. Can that be regularized, basically, throughout? And will that actually, and is that actually improving care for the other preterm babies? Or for term babies, actually, at the end of the day. Yeah, and that might actually help to reduce neonatal mortality rates, if that makes sense. So I think data is the first thing to do, and then use that data to actually push for services to be improved and to move that margin. Now, to move that margin, you need conversations between obstetricians and neonatologists. So put them in a room together, have that conversation, and then decide what the next plan will be. I think that's the best way to go about it.
Thank you for sharing your thoughts. Yeah, the challenge will be, how do you bring obstetricians and neonatologists plus palliative care providers like us in one room, and we sit down and actually discuss the process. Thank you. Dr. Beryl Okosa is asking, how do we assess quality of life in neonates with life-limiting conditions?
Quality of life. Well, you look at it as what do you expect a baby to do? And then is that baby able to do those things? Okay. So for example, if you have a baby who has been admitted into the neonatal unit, every day they're getting poked, and maybe they're wrapped in bandages or plaster or something to reduce their risk of maybe a fracture or something painful or things like that. So those are things to look at. So that's the benchmark, basically. So it's almost the same as what you would do with an adult. You compare what would be an average life for an individual and then compare that to what this particular baby is having. So most babies are born, they're held by their parents, they breastfeed, they are cuddled, they go to sleep, they wake up again. Cycle continues, basically. So if you have a baby who's not feeding or, can't feed, is not being held, is always being poked, has plastics all over in their body, basically, that question is whether that's quality of life. Now, it is worthwhile if it's for a short period of time. For example, like if you're doing that to a 28-weeker who will go home in about 6 weeks, then that possibly is okay. Now, if you're doing that in a situation where the baby is eventually going to die and you're doing it more and more and more, that is not a good quality of life, basically. So to have a baby being poked every hour for blood gas, or every 3 hours for a full blood count, or every 6 hours for a UEC, things like that, basically. So those are the aspects to look at. That's how I would look at it, is what would an average normal baby be doing or having right now? And then what is this baby that you're taking care of? What are they actually receiving at this point? And then seeing that put together, basically. Most babies are with their parents. They're not in the NICU, being cared by, what you call it, strangers, basically, throughout.
Thank you. Looks like we need to actually develop a validated tool for measuring quality of life of neonates or around perinatal area. But I hear you. Thank you very much. There are comments in the chat from Dr. Asaf Kinyanjui. We also need to advocate for hiring and deployment of psychological providers, especially at the sub-county level. I'm not sure this was in relation to maybe to support the perinatal care. Maybe Dr. Kinyanjui, you could elaborate a little bit. As we think about that, there was that aspect where you said all perinatal deaths, there should be a post-mortem done. And I know a number of the listeners, the webinar attendees are like, okay, is this really possible? There are things about cost barriers, there's resistance sometimes from relatives, and yet we are saying this is an important aspect. Might you want to elaborate a little bit more on that? So and how we navigate the cultural and other barriers around postmortem? You are Kenyan, so I'm sure you know.
So one, it should be offered. And then two, there are pathologists who sort of have an interest in it. So I think if you've met Dr. Edwin Walong, he has an interest in perinatal pathology, basically. So it should be offered. Now, in some cases, and it happens everywhere in the world, there are places where you will offer it and the parents will say, no, we don't want it. And there are cases where some parents will say, we want a postmortem, but you don't think it's appropriate. You know what I mean? So it just depends on the situation. So in some cases, if you've completely exhausted your diagnosis, you know how the kidneys look like, you know how the heart looks like, you know how the lungs look like, you know how the brain looks like, you have a genetic or whatever diagnosis down, and the baby dies, you don't really need postmortem. But if you have a baby who suddenly dies, you need to have a postmortem done. Now, to approach it is different, basically. So, and it depends on the family. You will offer it to them and they will give you their, their opinion, basically. Now, from a cultural and religious perspective, you need to work around it. And if I'm not wrong, I think there are certain hospital deaths that warrant a postmortem, I think from a legal perspective. So you would go around that the same way you would go around this, basically. If I'm not wrong, I think there are certain hospital deaths that actually warrant a postmortem. So you would just have to talk to the parents or the family and let them know that this baby had a sudden death or this baby died in theater, and that warrants a postmortem. And the coroner or the pathologist, the government pathologist has said we have to do it, blah, 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 whatever. Basically, it has to be done. So you have to talk to the parents and explain to them that it'll actually give us more answers and we can try to do everything within your stipulated time. So say, for example, if you're dealing with a Muslim family and they need to bury, within 24 hours or something like that, you just have to tell them that it may not be possible to do that, but you can try and do it in as soon as possible, and then have them have the body back if that's what they need. And try as much as possible to do an extensive examination once the baby dies. So if you need any fluids, whatever it is that you need, you could do that. Now, so in UK, you can't consent parents for a postmortem unless you've gone through training. Now, and the way the postmortem is done is it's different, basically. So you can have an extensive full postmortem and you can have a limited postmortem. And you need to talk to the parents. So you essentially, when you talk to the parents, you give them all those options. Of course, if they do a limited postmortem, there's limitations in terms of whether you will get a diagnosis or not, but you try as much as possible to do something like that. And then, so those are the conversations you can have. I'm not sure, I think, having had a relative die sometime this year, and I actually had to have talked to Dr. Walong in terms of what we could do for a postmortem, because the family needed a postmortem, basically. And we actually did a semi-limited postmortem because of cost, basically. But there are ways to go about it and figure out what you could do. So if you do a limited one, you could get fluids out, you could get biopsy, you could have the family have the baby back, and then they can bury, basically, and you do the test, basically. And you can actually store some of what you have. So in some cases, you can take the cord if it's an early death and store that for DNA if that needs to be done, basically. And studies can be done afterwards. Yeah, so there are options. And if the parents are not willing, you offered it, you tried to consent them for it. If they denied, then you just tick that box and you say they didn't want the postmortem done. I think it is important because you get a diagnosis as a unit. You're able to figure out, oh, actually, there's nothing we could have done in this death. This baby had X diagnosis. It's lethal. Or, oh wait, actually, we missed hypoxia. So I think this baby, or maybe there was an obstruction somewhere, or we did this, or there's a clot, or whatever it is. It actually helps in terms of care in the unit. And then the third situation is it actually helps the family. So if you have a genetic diagnosis that is X-linked, and both parents have this genetic abnormality, so chances are that this will keep recurring over and over and over. Will it help them to know? Some families may want to know. And then in the African setting, as you said, some parents will find out and divorce. It happens all the time. Or he'll go and look for a second wife. So it is helpful one way or the other, in my opinion. So it's something to be offered.
Thank you. Thank you so much, Dr. Frannis Okara, for sharing your thoughts. And we have personally enjoyed, and I'm sure members of the webinar. I don't see any additional questions on the chat box. But I know we can always we have many questions that we can always, we will continue to interact. And if we have additional questions, or we want you to share additional thoughts, we will definitely reach out. Since I don't see any additional questions on the chat box, I think at this point, I would like to appreciate you very much, and then return the session back to Dr. Beryl. Thank you so much. Yes.
So just something to mention. So Beryl, Esther, and I had developed, or rather they developed a survey just to figure out the need for neonatal perinatal services, palliative services. It was sent out to the pediatric support group, and I think it was also sent out in the neonatal group. If there are people who are outside those two groups who would like to fill in the survey, we can talk to Beryl and you can actually see which other groups to send it to, because I think it actually it will help us in terms of figuring out where we are and what kind of training needs to be done and what else we can do to scale up the services of palliative care.
Thank you. Dr. Berry, back to you.
Thank you so much, Dr. Fanny Sokara and Dr. James Akiruga, for the wonderful session that we've had on neonatal palliative care. Indeed, it is an area that still needs a lot of input, both in human resource and otherwise, and we're going to work on it. The work is already in progress. I will share the link on the inter-county group. For the people who are not there, maybe I can share it in this chat, even as we conclude. And please feel free to give in your inputs. It was originally tailored for neonatologists, but if you find that there are questions that may still apply to the field that you're in, kindly feel free to fill it in. Otherwise, thank you so much for joining, and we hope to see you in the National Palliative Care Conference to be held in February of 2026. Asanteni sana. Have a good night.